Good morning, everyone. Thanks to the organizers, respected chairpersons, and dear colleagues. So this is the paper which I will be presenting today. It's ICUD versus open cystectomy. It's a 3-year outcome. It's not the IROC trial. It's a single center trial out of Italy. So their hypothesis was all previous trials had used extracorporeal diversion. So they would like to use an intracorporeal diversion to compare to open cystectomy. And the IROC trial had just been published in 2022, which was after the initiation of this trial. And it showed a 2 days out of hospital advantage for robotic cystectomy with intracorporeal diversion at 90 days after surgery. So that was their primary endpoint. The primary outcome for this particular paper was a 50% reduction in transfusion rate, and they had a standard indication of transfusion of hemoglobin of less than 8. There were a number of secondary outcomes which have thrown up a few interesting results, as we shall see. So this was a single center RCT, began in 2018 to see clinical stage T2 to T4, N0, M0 or T1 post BCG failures. And exclusions were palliative surgery or any contraindication to robotic surgery. So they calculated a 58 in each arm sample size with 80% power to detect the 50% reduction in transfusion rate. And there were 2 surgical teams involved, each with at least 50 procedures per year in the 2 years prior to enrollment. So that's a very high volume center, almost cystectomy every week. And extended pelvic lymph node dissection was done in all cases. And there was a standard statistical analysis. So this is the consort diagram of the trial. Almost 274 patients admitted for cystectomy. 96 of them were palliative. And they were able to randomize 58 to each arm as per the trial protocol. In terms of the baseline characteristics, what was important was about 40% had neoadjuvant chemotherapy, which is more, in line with the developing countries, and in the US, maybe in high volume centers, it's a little higher. And again, interestingly, almost 75% in both groups were neobladders. In India, probably it's the other way, where 75% would be conduits. So these were a couple of interesting things on the baseline characteristics. Pathologic data, there was no difference in the final PT stage in both the groups. Majority were T2 and below, and about 35 to 36% were T3 and above. And 86% had no lymph nodes positive. And the median lymph node counts was not significantly different, and the positive margins were 0 in both the groups, so which was a pretty good standard of surgery. The results for the other outcomes showed, of course, the transfusion rate was much lower in the robotic arm, which was to be expected. It has been proven in multiple papers before. The operative time was higher for the robotic with intracorporeal diversion. There was no difference between the time to nasogastric tube placement or removal, time to flatus, time to bowel movements, time to mobilization or diet. No difference in complications, no difference in readmissions. So overall, this was showing a pretty much standard as compared to all the previous trials. And because the ERAS was used in all the cases, so possibly that would have had some role in, getting the patients mobilized and recovered faster. And what was interesting is that the hospital stay was also the same, which has actually been shown to be less for the robotic group in number of randomized trials, but here it was 9 days versus 10 days, which was not statistically significant. This is an interesting part where the costs of both the surgeries were analyzed, and because of the surgical costs being much more in terms of robotic usage, the overall cost of the robotic surgery was more than the open arm. So despite the fact that blood transfusions would have been less, the patient may have gone home a day earlier, it didn't mitigate the significantly higher costs of the surgical device. It's almost 8,000 euros versus 2,000 euros, which seems quite a lot. Oncologic differences were not to be seen. They were more or less equivalent. And one other interesting secondary endpoint was that the neobladders they analyzed, The ones with the robotic neobladder had significantly more nighttime pad usage. And that is something which is hypothesis generating in this paper. So just to go a bit in detail of how the costs were calculated, the OR costs in Rome are about 31 euros per minute. Hospital stays 830 euros per day. Blood transfusions 400 euros per unit, and ICU of 1168 euros per day. So this was a good breakup that they were able to give us, which is often hidden in most papers. So I think this was something worth studying. And despite all this, despite some mitigation from early discharge and recovery, still the robotic cost was so exorbitant that they were not able to, it was still overall much more expensive. And their hypothesis for the worst nighttime continence in a robotic ICUD was, a neobladder, was that it could be because it's a smaller reservoir with lower compliance, and that causes more leakage at night. They did analyze quality of life. At 6 months, it was equal, but they found for some reason better body image, bloating and flatulence for robotic surgery at 12 months can't really be explained scientifically. It was just probably an observation that they were able to generate. So it is a single high volume center. So the generalizability of these results is a little difficult. And it is underpowered for the secondary outcomes. So definitely these are worth studying in future trials. So our analysis and conclusions, they used a primary endpoint which was already well proven in the literature at the time of the initiation of the study. Even in extracorporeal diversions and robotic cystectomy, the blood transfusion is much, much lower, and the blood loss is much lower as compared to open, and that has been well proven across multiple studies. So this choice of endpoint was a little surprising. The data on costs, at least from Europe, is very interesting. I don't think in India the costs are that much. Almost 4 times surgical costs seems a little higher. But definitely the cost effectiveness of a robotic cystectomy is very much questionable. They didn't provide any data on the ureteroenteric anastomotic strictures, which is something people claim that it's much better, much lower in intracorporeal diversions. Use of Firefly technology may help in that. There was no difference among a lot of the secondary outcomes. So my question is, what exactly is the benefit of intracorporeal diversions? Possibly worse nighttime continence in an intracorporeal neobladder, which is worth studying in future papers. So is this paper practice changing? Possibly. For me, I will only do an intracorporeal diversion if the patient insists. Otherwise, I'm quite comfortable offering extracorporeal diversion or even an open cystectomy. It's definitely not an inferior operation. Thank you.